Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I am Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabeg people. We are grateful to have the opportunity to be present in this territory. Today, we're delighted to welcome Children's Healthcare Canada member, McMaster Children's Hospital, for Adrift Between Systems, Transition Experiences of Youth with Medical Complexity and Their Families. As mentioned in the intro video, please type your questions into the question box at any time. I'll prompt you via the chat box as well, and I'll pose the questions to our panel at the end of the session. Now I'd like to introduce our speakers today. Lynn Lee is a registered nurse on McMaster Children's Hospital's Pediatric Medicine and Complex Care Inpatient Unit and a PhD student in the School of Nursing at McMaster University. Her doctoral work focuses on supporting the transition to adulthood and transfer to adult services for youth with medical complexity and their families. Marissa Bird is a PhD student in the School of Nursing at McMaster University, studying digital health innovations for children with medical complexity and their families. Her work focuses on enabling children with medical complexity to be cared for safely at home by leveraging digital technology to connect families with healthcare providers remotely. And Dr. Jan William Gorter is a professor in the Department of Pediatrics. He's a director at and scientist at CanChild Center for Childhood Disability Research and holds the Scotiabank Chair in Child Health Research at McMaster University. And Jan is also a visiting professor in pediatric rehabilitation in Utrecht, the Netherlands. It is my pleasure to pass the mic now to Lynn.
All right, thank you, Paula, for the introductions. So I'm Lynn, and here with me today are Marissa and Jan Willem Gorter. So today we will be talking to you about a qualitative evidence synthesis that we did on the experiences of youth with medical complexity and their families with the transition to adulthood. This work was recently published as an open access article in the journal Transition Medicine. So I welcome all of you to have a look at that if you're interested in learning more of the details of what we're going to talk about today. So first, we would like to begin by acknowledging that McMaster University and Hamilton, Ontario are located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. That wampum represented here uses the symbolism of a dish to represent the territory and one spoon to represent that the people are to share the resources of the land and only take what they need. We recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have with this land. We would also like to thank our co-authors, Dr. Nancy Carter, Dr. Jenny Plow, and Dr. Patricia Strachan, who are faculty members in the School of Nursing at McMaster University. We have 3 learning objectives for the next hour. First, to describe how youth with medical complexity and their families experience the transition to adulthood highlighting the different aspects of their lives that are impacted by transition. Second, to identify contextual factors that influence transition experiences. And third, to understand the implications of the findings for practice, policy, and research in Canada. And next, I'll pass it over to Marissa.
Thank you, Lynn. So to get us started, I thought we'd just do a bit of context setting to talk about the definition of children and youth with medical complexity, or CYMC or YMC, and distinguish between the notions of transition and transfer. So starting with a definition here, CYMC are a unique group that are identified by their needs and complexity rather than a specific diagnosis. So the first defining feature that I should mention here is that this group of children, youth, and their families are incredibly resilient and absolutely wonderful to work with. Definitions for this group describe issues faced by these children and their families not to diminish their strengths, but to characterize and appreciate the substantial hardships faced. So this group has been defined by 4 characteristic features, which Cohen and Colley describe as 1 or more chronic conditions, substantial family identified service needs, severe functional limitations, and high utilization of healthcare resources. Because of their fragile health and extensive caregiving needs, both CYMC and their families are at increased risk for poor physical and mental health, as well as social and financial hardships. So these conditions affect their lives in multifaceted ways. Risks for CYMC in particular include greater rates of developmental, emotional, and behavioral problems, recurrent hospital readmissions, medical errors both inside and outside of the hospital, and generally fragmented or uncoordinated care. In addition to this, family caregivers report poor physical and mental health, problematic family functioning, increased social and financial hardships. And in terms of healthcare utilization, this is a very small population we're talking about. In fact, less than 1% of our pediatric population in Ontario, yet they consume disproportionately up to 1/3 of all pediatric healthcare spending. So what this means for us is that finding better ways to support these children and youth with medical complexity and their families will also result in benefits for our healthcare system and decreased resource utilization. Next slide, please. So sometimes when I talk about this group, the best way really to illustrate is with a case. So just for a moment, we're going to focus on Abigail. Now, Abigail is a 16-year-old youth with cerebral palsy, epilepsy, developmental delay, and gastroesophageal reflux disease. She's completely dependent on her family for basic needs, things like feeding, toileting, bathing, and mobility. And her family also need to manage medications, therapies, medical devices, things like feeding pumps, oxygen, and suction machines. Abigail is frequently hospitalized, and this means that not only is there disruption to her life and development outside of the hospital, but her parents need to take time off work, and it can also result in disruption to things like her siblings. So as you can tell, transitioning Abigail from a pediatric to adult service would be a large undertaking, and this is what we're going to discuss next. Next slide, please. Now, transition versus transfer. I think it's important for us to understand that while the words transition and transfer are often used interchangeably, they have very different connotations and they're understood differently by healthcare providers, family caregivers, policymakers, researchers, and so on. You can see here in this illustrative quote, one parent equates transition to actually falling off a cliff. Next slide, please. So in our work, we conceptualize transition as the purposeful planned movement of youth from child-centered to adult-oriented healthcare systems. Transition should be uninterrupted, coordinated, developmentally appropriate, psychologically sound, and comprehensive. Next slide, please. Conversely, transfer is a one-time event that occurs when a youth is transferred out of the child healthcare system and into the adult care system. And while healthcare providers tend to be more concerned about this transfer of care, what youth and families actually experience is a much more complicated transition that may span several years. Next slide, please. Now, this transfer of services is especially difficult for CYMC in particular because of the sheer number of services that they access. So because of their medical complexity, they're often followed by many different providers in a variety of care settings. For example, one study found that they were cared for by a median of 13 outpatient physicians from 6 distinct subspecialties. To illustrate what this looks like, what you see here on your screen is a care map drawn by a parent of a child with medical complexity, illustrating all the different services that they access. And when CYMC age out of pediatric care, many of these services need to be transferred individually, speaking to the magnitude of complexity of this task. Next slide, please. So because of the complexity of transitions, we wanted to really take a holistic approach in our work. So we recognize that there are actually multiple transitions going on at the same time, and some of these include the transition of health, social, and education services, developmental transitions such as attaining adult milestones, for example, related to vocation or independence, changes perhaps in living situation, and relationship changes, both within the family unit, with their peers, and with service providers. Next slide. So the aim of our meta-ethnography is to explore how youth with medical complexity and their families experience the transition to adulthood and the transfer from children's to adult services. Next slide. Now, really briefly, I'm just going to take you through the methods quite quickly before Lynn gets into our findings. So some of you might be wondering what exactly is a meta-ethnography, which is a fair question. So essentially, meta-ethnography is a rigorous inductive and interpretive research method for synthesizing qualitative literature. So looking across qualitative studies and distilling out some of the findings from across studies. Next slide. So we do this in 7 iterative phases. The first phase is to define a gap, which we have just talked about. Next, what we did is we undertook a rigorous literature review. So we searched across 6 health and social science databases. We hand searched relevant journals, websites, and articles. And what we were looking for was qualitative research looking at youth, transition, and medical complexity. Next, we read the studies and conducted a critical appraisal before extracting data about things like the study aims, the context, the population, and key concepts. Now, steps 5 and 6 are really where the meat of the work is here. So step 5, we translated studies into one another. And what that means really is that we're combining studies, comparing and combining key concepts while trying to maintain the original context and meaning from each of the studies. So we're looking across study to see where the similarities are while trying to maintain some of that original context. And finally, synthesizing translation. So we do this using something called a line of argument synthesis. This is really a fancy way of saying that we're developing a theory about a phenomenon based on the translations of included studies. So finally, we're expressing the synthesis, and as Lynn mentioned earlier, we have a newly published open access article in the Journal of Transition Medicine. If you are interested in much more detail on the methods or findings of our work, I just invite you to look there as well. And so with that, I think I will pass it over to Lynn, who's going to look at some of the findings of our work with you.
Great, thank you, Marissa. And I apologize, my slides seem to be like advancing on their own, so just trying to manage that over here. So the findings of our work, these were our search results. We originally had 16 articles that met our eligibility criteria, representing 14 studies. However, we looked at what really made sense to synthesize, and we decided to include 10 of these studies that really fit well with the aim of our meta-ethnography. So of these 10 studies, 9 of them used qualitative designs and 1 used mixed methods. Half of the studies were actually conducted in Canada, with the others being conducted in the United States, United Kingdom, and Ireland. And there was a good mix of youth and parent participants. So 7 of these studies had youth participants and 8 had parent participants. And many studies had both. As you can see, there's some overlap there. So there were 2 main categories of transitions that we came across. There were service transitions. So these were transitions in the health, education, and social sectors, as well as developmental transitions that were related to changes associated with growing up. And we found that youth with medical complexity, for them, these service and developmental transitions were often very closely interrelated. So for example, youth and their families often desired for the youth to become more independent from their parents, but this often depended on appropriate supports and successful service transitions. Also, transitioning to adult services often meant that youth experienced increased autonomy in their care, and this sort of signaled a coming of age as they realized they had to become more involved in their care. So the service transitions and developmental transitions influenced each other. And to synthesize the included studies, we grouped the conceptual data into what we call first, second, and third order constructs. So first order constructs refer to the study participants' views, and these constructs were first developed by looking at the direct quotes that were reported in the studies. And then second order constructs refer to the study authors' interpretations. So these were things that the study authors of the included studies talked about in their discussion or conclusions. And finally, the meat of our meta-ethnography are the third order constructs, which are our interpretations as reviewers of the second order constructs. So how we came up with these was that we used the second order constructs, which we had identified 16 different constructs, and we created 6 thematic groups. So that's kind of what I'll be talking about today, the third order constructs, and I'll just go through each one. So the first construct that we came up with was the nature and process of transition. We found that transition was multidimensional and affected many realms of the youth's and families' lives. For example, transition affected family functioning, social participation, and the health and safety of the youth. Transition also involved multiple services, providers, and sectors. And despite this multidimensional nature of transition, providers tended to focus on the one-off event of transfer rather than a more holistic transition to adulthood. Transition also tended to be defined by static, system-mandated critical time points, such as the age of transfer or age-related service and funding cutoffs. The second construct was changing relationships. So youth and their families had grown up in children's services and had formed long-standing trusting relationships with their providers. The transfer to adult services then led to feelings of loss and sometimes abandonment when these relationships ended. Youth and their families also felt the loss of familiar settings and practices, such as those that they had experienced in pediatric hospitals. However, establishing new positive relationships with adult providers helped youth and their families feel situated and develop confidence moving forward. Relationships also changed within the youth's family in response to their developing autonomy and, in some cases, the youth's declining health status and increased need for parental caregiving. The third construct that we looked at was goals and expectations. So we found that youth and their families have goals for adulthood that focus on promoting and enabling the youth's independence and autonomy to the best of their capacity. For example, they desire and try to plan for a good adult life, and this could mean things like participating in work, education, social relationships, and their community. However, realizing these goals was often dependent on an enabling environment and was often limited by financial and system barriers. Despite these barriers, youth and their families demonstrated incredible resilience and perseverance in pursuing their goals. The fourth construct was actions related to transition. So these were actions that were taken on by youth, their parents, as well as their providers, with the aim of planning for and facilitating transition and working towards the youth and families' goals for the future. So we broke the actions down into advocating, networking, communicating, collaborating, and finding information. For example, youth and their families advocated for the youth's role in decision-making and for appropriate services and supports. Effective communication and collaboration between all parties helped to facilitate the transition, whereas a lack of communication or poor communication led to a very abrupt and disorganized transfer. Youth and their families also wanted reliable and accessible information related to transition. However, this information was often inconsistent and not readily available. And as a result of this patchy network of information, they often relied on themselves and on peer networks for information gathering and also for advocacy. These actions, we think, highlight the resourcefulness, creativity, and unique skills that youth with medical complexity and their families have developed. However, it also highlights that we need to be doing more to help them instead of the youth and family taking on all of these actions. The fifth construct was making sense of transition. And what this means is how youth and families emotionally processed the transition. And this would often be associated with uncertainty and inner turmoil, but at times could be empowering or lead to a feeling of being respected and valued. Transition was often filled with uncertainty about things like the future, who would care for the youth, and what services and supports would be available. A positive aspect of the transition was that youth actually experienced a newfound sense of independence and being respected due to their adult status. So they also felt increased autonomy and self-esteem as a result of that. On the other hand, youth and their families often experience patronizing attitudes and discrimination in the adult system based on the youth's disability, and these experiences were very disempowering for youth and their families. The last construct was contextual factors impacting transition. So these included youth factors, family factors, social factors, and system factors. Examples of youth factors included things like personal attitudes and resilience, their strengths and as well as functional capacities, and medical stability and complexity. Family factors included things like information and preparation related to transition, parental health status, and competing family and caregiving demands. Social factors included support from others, such as families, friends, and peer support groups, as well as the community and service providers. And lastly, system factors included things like perceived limitations of the system, poor accessibility of information and services, and the stark differences between children's and adult services. So using these 6 third-order constructs, we created what is called a line of argument synthesis, as Marissa explained. So this is a conceptual model that just links all of those third-order constructs together. In this model, youth with medical complexity and their families experience transition by making sense of the dynamic interplay between goals and expectations, changing relationships, and actions related to transition. Being respected and valued helped to contribute to youth and family empowerment and positive transition experiences. Also, youth and their families felt supported and empowered when their actions led to realizing their goals or to positive relationship changes. These experiences allowed the transition to progress forward. On the other hand, if these actions were ineffective or led to negative experiences, youth and their families would feel uncertainty and inner turmoil. And this whole experience was defined by the nature and process of transition, which was often bounded by system rules. And the experience was also influenced on all levels by the contextual factors surrounding the family and the transition. So now I'm just going to go back to our original illustrative case that Marissa had introduced of Abigail and her family. And I'm just going to apply this model to her situation. So, for example, Abigail and her family have goals for her future living situation. Her parents really would like her to live at home with them, but they are getting older too, and they're not sure how long that they will be able to care for her. So this leads to a sense of uncertainty about the future, causing inner turmoil. As a result, they take action by looking for information on other living options and advocating for the supports she needs. And whether they're able to find something that meets their goals or not will determine how they make sense of the transition and whether they continue to feel that strong sense of uncertainty or not. Also, different outcomes will have different impacts on their relationships within the family. Looking more at services, Abigail and her family will have to prepare to leave pediatric services and find new adult healthcare providers. Ending these relationships with their pediatric providers might create a sense of uncertainty again, which then compels her family to take action and establish new relationships with providers, with adult providers. How these families make sense of this service transition will be influenced by their expectations for the future and also for these new relationships. So what are the implications of our findings? A strong theme in the included studies was that transition is very emotionally burdensome on the youth and their families due to these feelings of uncertainty, loss, and abandonment that result from this really abrupt termination of services and relationships. Parents also described increasing difficulty in managing ongoing care needs while also having less energy as both the youth and the parents got older. Therefore, we think it's crucial that providers offer family-centered support services to address these emotional needs of youth and their families, and also to begin planning for transition early to avoid those feelings of sudden abandonment. If possible, it's also very helpful for youth and families to be able to connect with adult providers well before transfer. It's also important to ensure access to accurate and consistent information about services, supports, and resources, and to communicate and collaborate with all involved stakeholders across agencies, sectors, and children's and adult systems. Another finding was that transition was associated with a sense of crisis. And this is likely due to healthcare providers in these studies focusing on the one-off event of transfer rather than a more gradual and holistic transition process. Therefore, it's also important for providers to take the time to really discuss with the youth and families what their goals and visions are for the future and how they can be supported in achieving these visions. In this way, providers should take a more holistic approach to transition, not only focusing on transfer, and to look at the transition as a journey rather than an event or outcome. So many of these practice recommendations are not new or unique to this population, as we have found. They are already part of current practice guidelines like the Canadian Transition Guidelines, which can be found on the Children's Healthcare Canada website. However, our findings do highlight that these recommendations are not being implemented, or at least not being implemented consistently across practice settings. And we think that this sort of patchy implementation is not due to a lack of awareness of current guidelines, because in fact, there does seem to be some evidence of increased uptake over time. And that suggests that providers are aware of current recommendations, but are just not able to consistently apply them. And so we think that this is because transition planning is very time consuming, and it's likely that this lack of time and resources, along with the lack of incentives, stops providers from really prioritizing transition planning activities or leaving it to the last minute. So that therefore at the system level, we think that policymakers should really consider developing or improving policies that will better support providers in implementing recommended practices. For example, allocating dedicated resources for transition. Policies should also focus on using incentives to drive system change, such as financial incentives or holding organizations accountable to quality standards for transition planning and continuity of care. Policymakers should also consider adopting flexible policies for age-related cutoffs for services and funding. And this should be tailored to individual youth development and family needs. And this recommendation is not meant to simply delay the same issues, but rather to allow for additional time for transition planning and to give families more flexibility when they need it. Policymakers should also work with other sectors, such as the social and education sectors, to break down silos, as these sectors do face similar challenges related to transition, and these silos are a big barrier to effective transition. Lastly, there should be a focus on strategies aimed at capacity building among adult providers and social inclusion of youth with medical complexity and their families. Lastly, there were several research gaps that we identified. For example, the family experiences that we came across almost exclusively focus on primary caregivers, in particular mothers. So we do need a better understanding of how transition affects the whole family. There's also little data on cultural influences, which is likely to be an important factor as the transition to adulthood is very much a socially and culturally situated phenomenon. It was also clear from our findings that youth with medical complexity and their families have substantial unmet emotional needs. So further research is definitely warranted to explore these needs and how best to address them. There was also a strong focus on barriers and facilitators as having a very linear relationship with transition. And the gap here is to really identify how these factors interact and manifest in different contexts. As we know, transition is a very unique and contextual thing for each family. And also, while there were 5 studies that were conducted in Canada with youth who we deemed to be medically complex, there were no studies that focused specifically on this group within the Canadian context. So now I'm just going to pass this over to Dr. Gorder to talk about some transition initiatives and work in Canada.
Thank you, Lynn. And following this presentation, where we zoomed in on youth with medical complexity, I want to zoom out a little bit, because we know transition is a much larger issue for children, youth with chronic health conditions, physical conditions, mental health conditions, and developmental conditions and medical complexity. And Lynn and the team did a great job in looking in what's out there in the literature. To bring it to life, I want to start off with sharing a video with the story of Noor that was recorded 5 years ago at Hamilton Health Sciences. A family that went through the transition process. It's a 5-minute video that will show that growing up is hard for any teenager, but in particular for Noor and his family.
Noor, he's 18 years old now, young man. Noor was diagnosed with CP at early age. Noor never walked or very minimum talk. He's not quite verbal, but we understand him. He has a lot of facial expressions.
He's a wonderful young man. He is always happy when I see him. He is one of the young men that is, I think, happy to come to clinic. He loves attention, and he's a wonderful person to work with.
From the first visit, Noor was laughing. Dr. Gordon made him laugh. He joked around with him, and so they became pals. So right from the beginning, it didn't take really more than for the first appointment.
So we always think of what's coming next, and we also know that young people like Noor have similar ideas about the future and want to live a life as an adult. But also the families have a lot of anxiety what's going to happen. So it's, I think, important to start early having that sort of conversation. Okay, what will happen when you turn 18? And in particular, if you are turning 17, we start to talk about how special that year is, because we're working towards a moment that the children will leave the children's hospital. I like to say that they graduate from our program to move on to the adult rehabilitation services.
He came to the room and he told Noor, he said, Noor, you're 17, next year you'll be 18, and this is a very, like, we have to prepare you for that year.
Noor's mom was extremely nervous about that change, and she could express that. That was helpful too. She could let me know that she was anxious about it. So then we could have a conversation about it, and I said, well, let's work on this together. Let's find a doctor who can continue the care that I trust, and see if you feel comfortable working with him before I actually say goodbye to you.
But that's the sweetest thing about him. He said, not to worry, Mom. He discussed every step of the way. He told us about the option of doctors at the regional rehab, and he mentioned names, and he said, I'm trying my best to find the right match where this doctor will follow in my steps. He comes to the hospital expecting more than just treatment.
It's a bit frightening moving from a team that you know and have been with for so long to a new team, and so that's why I think that it's so important to have this transition early before it's actually required that I take over.
Most important thing is that transition is not a last visit, but it's really a purposeful, planned movement towards transition. That can start as young as age 14, but in particular the last year will be very focused on getting the family ready for the transition.
I think by and large the most important issue is the human aspect. The kids coming into, or now adults or almost adults, coming into a completely new environment with new people need to know and have a sense of trust.
My fear was, would they treat Noor the same way? Would they treat me the same way? Would they think of us like we're human beings, we're here for a visit, but we're lifelong struggle?
Working with Noor and explaining the family what it is about when you leave the children's hospital and what you can expect in the adult services, knowing that there is someone out there, another doctor and a healthcare team that can continue the care, and also giving that trust that they will be taken care of. I think that's critical.
Of course, you want to do the best that you can for each and every patient from a medical perspective, but having a patient in an ongoing relationship, you get to see them grow and you get to see them experience different things in life. It is very rewarding to be a part of their life in that way.
You know what makes you great? I know you're great in your profession, you're a great doctor, but that's not what makes you great. The greatness of you is you don't separate the human being in you from your profession. And that's where I'm very thankful to Dr. Gorter, because, oh my goodness, he made it like from impossible to possible.
So we know that there are still a lot of families that need our care. We need to look after and care and help them prepare, and also throughout the transition into adult services. I want to zoom out a little bit and talk with you about some next steps and things we are working on with Children's Healthcare Canada from coast to coast. Next slide, please, Lynn. So now we are in a pandemic, and a lot of our care is now happening through virtual meetings, but that doesn't necessarily make transition easier, and we have to, and we will discuss this, what are some opportunities, but also what are some new challenges during this wireless age. Next slide. So I wanted to share with you that we have been working for a number of years with Children's Healthcare Canada on first the development of the transition guidelines that was referred to earlier today, but also on a collaborative Canada-wide approach to overcome the fragmented services provided during the transition to adult care. And we strongly believe that through national opportunities, we can learn from each other and we can develop realistic solutions to promote the best possible health outcomes for patients and families. On the next slide, you will see that we now are one of the couple of child health hubs that were founded last year in 2019. There's a special health hub on transition to adult healthcare, which aims to create a knowledge network that seeks to bridge the gap between current treatment practices and evidence-based solutions for healthcare transition in Canada. Next slide. We have grown since the start last year to 84 individuals from across Canada, including healthcare providers, researchers, young adults with special healthcare needs, and parents. And you can see the distribution from the different provinces currently as members on the Health Hub in Transition. Over the past year, we have hosted 11 online meetings and 1 in-person meeting last year at the Children's Healthcare Canada Conference in Ottawa. So if you are not yet a member of the Health Hub in Transition and you would like to be part of this hub, you can become a member, and there are some exciting things I want to share with you. Next slide, please. You can become a member through the QR code here. I believe you can scan it. You can also send an email to dalemacaulay@mcmaster.ca, and or you can send me a Twitter message or an email, and we will connect you and welcome you to our next meeting that will be in December. What we have done with the Child Health Hub in Transition is also prepare a first Canadian Transition Conference that will be held as part of Children's Healthcare Canada conferences on January the 26th and 27th, 2021. It will be a virtual conference where we hope to connect youth, families, clinicians, and researchers across Canada working to improve the transition to adulthood. So please save the date for this first Canadian Transition Conference, and we will be sending out a call for abstracts and presentations shortly. This brings us to the end of the presentation, and I'll turn it back to
Thank you very much, Jan, Lynn, and Melissa. It's my cue to prompt folks to ask questions in the question box at this time. There's been some interest even prior to you saying so, Jan, about the Transition Conference, so that's wonderful. I'm glad you shared the graphic about that, and in the question box we have a few questions. I gave a little bit more information about that as well. And I don't see any questions coming in just yet, so I have a few of my own. With regard to your project, where to from here?
I can take that question. So this was like a really good look at the literature to see what is published. With the Transition Hub, we're also doing an environmental scan to look at what programs are currently available in Canada, what's happening on the floor. And then we're also conducting a study, which I will be leading for my doctoral work, that looks at how families of youth with medical complexity really adapt to this transition, and to really understand not just what the issues are and what their experiences are, because we know that there are poor experiences, there's uncertainty, and that there are positives, but we really want to understand how we can use those experiences and leverage their strengths, as well as looking at what are really the biggest gaps and what do we need to address moving forward. So there's sort of a few different ways that I think we can address transition in Canada, and to really look at the experiences of the families as well as what's happening on the ground.
What were the most surprising findings that came out of the work that you've been doing?
I think that the most surprising findings for me was when I looked into it, I thought that maybe there would be a lot of negative experiences and uncertainty, which certainly there were, but there were also a lot of accounts of youth resilience, families just doing tremendous work, reaching out to different services and providers to make those connections because they weren't connected by the system or by their providers. So I was very impressed by that and by the work that youth and families were doing. So that was probably the most surprising for me.
Fair.
Do you
And
have
we
anything?
often hear how much work that system navigation is, even within a familiar child and youth health system, but moving into a, I'll say it, strange to them, different, new to them, adult system. When you heard from families and young people about what worked, were there some key factors that we should all begin to build into our programs and processes now that might help?
I think that the key thing that really helped families was to have providers who were proactive and advocates, and kind of like that video where Nora's family, Nora's mom talked about providers that really cared and took the time to connect youth with the adult providers to collaborate, to set up these joint meetings in advance so that they had something to look forward to. I think that was the biggest piece that came across as successful strategies.
Oh, wonderful. A couple of questions have also come in from Jacqueline. What type of incentives do you think will be helpful for physicians and other healthcare providers in peds, adult healthcare, and primary care to enhance transition care? The incentives that might be available.
Jan Willem, do you want to take this one?
Yeah, sure. This is something we talked about quite a bit, actually, also in our Health Hub on transition. What really drives change is the question, and so at the system level, I think being accredited for the work for transition, being an accreditation indicator, would certainly help. I'm not necessarily sure that would be an incentive to individual physicians, but I think as a system, it certainly would work. And then there is also, and Lynn spoke to that one of the barriers might be time and to sort of dedicate to transition. And so I think if there is an incentive that transitional work could be incentivized by allocating time, that would either within an organization that people are dedicated, doesn't necessarily have to be a physician. I strongly believe in a team approach. So if anyone sort of on the team can be identified as being the key worker on transition, that could help as well.
Oh, thank you. Another question about whether or not government has been engaged in some of the work that you're doing.
I'm assuming that's around just transition work in general, not specifically this literature review. So
yes.
Jan Willem, do you want to talk about that as well?
Well, sure. I think the government is aware that this is an important topic. So raising, but that is never enough, I think, to raise awareness. There are still too many families, I think, suffering, and often it's very silent. So because they go through it on their own, and it's their own process, where we know there is a much bigger picture here and a larger issue. So it's good, and also this webinar is another way of raising awareness. I think in the past there has been For example, in Ontario, many initiatives, for example, with the Provincial Council for Maternal and Child Health, to develop also provincial guidelines and practical tools, as well as a newer initiative that has started or began last year and will continue this year and possibly next year on formulating health indicators. And I think that's a very important thing. If we together can come up with key indicators that would basically set the stage across Canada, what we aim for and how we can almost benchmark our transition outcomes and successes, that would be really good. The last thing I would say is that also through research, there is quite a bit of attention to it. For example, the Transition in Care program that was initiated by the Canadian Institute of Health Research has resulted in some very good projects. And also in the Child Bride program, which is a patient-oriented research program, there are projects specifically related to support transition of youth with so-called brain-based disabilities.
Thank you. We have an anonymous question, a question from an anonymous poster. We start discussing transition at age 14. However, I find that when we deal with some families, they're not able to identify future goals or actively engage in future planning because they're having difficulty managing, or they're just barely managing to cope with the day-to-day, and they're exhausted. And they have limited options for medically complex adults due to geography and wait lists and variety of other barriers. This person's interested in strategies to help those parents engage in the transition, especially when options are limited.
I think that this really speaks to some of what we found in this literature review, that families and the youth face, they're exhausted and they are overburdened and overwhelmed. And so in this case, it's not just looking at transition services, I think, and having options, but just having support in general for families so that they're able to manage the day-to-day care, so that they're able to be a parent to their children, and to focus on things like future planning, like any other regular parent would. In terms of having limited options, I think that's something that it will take time for those to develop, and we just have to keep working on this. But how to engage families when we do have limited options is, I think, just to look at what is there available to support families in their day-to-day care. Is there anyone that can help them with looking at services, with completing paperwork, and understanding that during these COVID times, that is even more difficult and more daunting.
If I may add to that, Lynn.
Yeah, of course.
Because I do hear the question, and transition is overwhelming. It's also very complex because there are so many aspects to it, as was shared in the presentation. What I've learned over time is also that it can help to break such a big topic down to really sort of manageable goals. And it also relates to seeing transition as a process, which ties into starting early, building that relationship, bring awareness, but also providing that reassurance that the family will be supported throughout the years. A challenging part is indeed finding providers once the children leave the pediatric healthcare setting. And that's something we need to work on. We need to build capacity. We know there are adult healthcare providers, there are excellent primary care providers, but it does take a lot of time and energy to find them and to build a network. And I'm fortunate to, over the years, to build such a network, for example, with specialists, but also with primary care providers. that truly helps locally to implement all these great ideas and transition guidelines. But you have to act. So think globally, but act locally. And that's what you need to do. You have to build a network and bring together adult and pediatric care providers together.
Speaking of the network, from the Health Hub's perspective, are there providers from both in that Health Hub?
The answer is yes, because we have a few from the adult side, but as we know, transition and the transition literature and everything is very pediatric driven. So that this is our goal to develop that relationship with the adult healthcare providers.
And from Christina, she's working on a project in youth healthcare transition and wants to connect with others. Do you suggest she get in touch with folks at the Health Hub?
Yes, please. Please do reach out and connect. As part of the Health Hub, we are also developing truly an online hub, a website basically, with Children's Healthcare Canada. And that will be a resource, and where we hope where that sharing would be across Canada much easier to know what other people are doing and potentially find other people to connect with.
Wonderful. I will type for this person Lisa's contact in the contact box so that she can link with her about joining the hub.
Mm-hmm.
Wonderful. Well, thank you very much. I think that's the end of the questions from the audience. I want to thank you so much for your time and for sharing your expertise with us. Thank you, Lynn, Marissa, and Jan. Thank you to all our members and other attendees for spending this time with us. We hope you depart with some practical knowledge to bring back to your organization. We have a fall-packed webinar schedule. Join us tomorrow at 11 a.m. Eastern for Ready to Work, development of a user-informed online employment platform for job seekers with autism. Another issue in the transition to adulthood for young people with neurodevelopmental disabilities. And next week on October 21st at 11 a.m. Eastern, we have parent and family important outcomes in neonatology. As well, registration is now open for our annual conference taking place virtually on November 16th to 20th. To register, visit our website, childrenshealthcarecanada.ca. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Lynn, Melissa, and Jan for this presentation. Thanks to Children's Healthcare Canada member McMaster Children's Hospital for supporting our webinar program. And hopefully we'll see many of you back here tomorrow. Bye, everyone.